Hello, everybody, and thank you for joining today's MIPS Value Pathways webinar. So the purpose of the webinar today is to provide an overview of the MIPS Value Pathways or MVP's participation framework, and after the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Katie Moore at CMS to begin.
Great, thanks, Lauren, and good afternoon, everyone. Thank you so much for joining us today. I know we're at full capacity for this webinar, so really appreciate you taking the time out to, if you haven't already been on any of our previous webinars about our MIPS Value Pathways, this should be some new information for you, and everyone else that's already heard this at other times, it'll be a good refresher on where we're headed with MIPS. Next slide, please. All right, so the first couple slides we have here are just really high-level overview of the quality payment program in general, and just some reminder information about the program and where we are, and then we'll get into where we're trying to take the program. So first slide here is just our graphic that displays, what the quality payment program is. As most of you know, MACRA required CMS by law to implement an incentive program, and that is where the quality payment program came from. There are two participation tracks in the program. So what we're mainly focusing on today is MIPS, so merit-based incentive payment system. And then the other participation track is our advanced APM, so alternative payment model. Next slide, please. And so MIPS was part of the quality payment program, was created combining really three of our legacy programs. Different pieces of those programs put together are now what we have for MIPS. So our Physician Quality Reporting System, or PQRS, is really the quality portion of our program, the Value-Based Payment Modifier, so VM, and then Medicare EHR Incentive Program for eligible professionals. So those bring together our cost and promoting interoperability parts of the program from previous legacy programs. And then we have our improvement activities, which was new for MIPS. Next slide, please. And I don't know if anybody else is echo on your end, but Kat and team, if we can, I guess, mute all of their callers, that'd be great. If we aren't already. Okay, so our next slide here is just really quick high-level overview of MIPS. So quality, cost, improvement activities, and promoting interoperability. And as you'll see on the screen, each of those performance categories have a weighted score to them. So quality, your quality score is worth 45% of your total final score for MIPS. Cost is 15%, improvement activities is also 15%, and then promoting interoperability is 25%. So this is for the 2020 performance year of the program, which is the current performance year we are in. We always like to remind ourselves and everyone else when we're talking webinars what performance year we're talking about, since we overlap a lot of parts of our program. Next slide, please. So current participation in MIPS. So what have we been hearing from a lot of our participants? So a lot of clinicians, we've heard that the current structure of MIPS and reporting requirements are too confusing. There's too much choice. There's too many measures and activities to select from. People aren't sure, what exactly they should be reporting on to report meaningfully. The measurement activities aren't always relevant to a clinician's specialty. And it's hard for patients to compare performance across different clinicians because different clinicians that may be the same clinician type are reporting on different measures. So it's really hard to compare them across the board. So next slide, please. So that's where our MIPS Value Pathways, so MVPs, is going to start coming into play here. So while we've had some incremental changes to the program each year since its beginning in 2017, we recognize additional long-term improvements are needed to align with CMS's goal to develop a really meaningful program for each for each clinician that's participating in the program. So regardless of your practice size or what specialty, we really want participation in this program to be meaningful to how you practice. CMS is committed to the transformation of MIPS, so through MIPS Value Pathways, so MVPs, and this is our new participation framework that's going to begin in the 2021 performance year. So that's important to remember that all the work we've started doing last year and then this year to get us to our MVPs, they won't begin until 2021. And with that, I'm going to turn it over to Molly to give you some more information about MVPs and where we're headed.
Okay, thanks, Katie, and thank you again, everyone, for joining today to hear about our new MIPS Value Pathway participation option. So, as Katie had mentioned, some of the things that we're trying to address under the new MVP framework are really based off of all of the feedback that we've been hearing from all of you since the program initially began back in 2017. We also have seen under the MIPS program to date a really high focus on participation, and we're really pleased to see that there has been so many additional clinicians that previously haven't participated in quality that now are. So for folks who may recall back to the first year of the program, under Pick Your Pace, we had set participation goals of having 90% participation. And we actually surpassed that goal within the first year. We had 95% participation, and then last year we had 98% participation. So again, we've seen clinicians who previously never were engaged in quality reporting or quality improvement that now are engaged, which we think is great. But now we really want to shift the focus of the program to not only participation in quality reporting or quality improvement, but also really moving the needle forward on value. So really ensuring that the program is one of meaningfulness. So as part of that, we've come up with our new MVP framework, which we anticipate will help remove barriers to APM participation. Again, as Katie mentioned previously, under QPP, there's two tracks, MIPS and APMs, and we do want to encourage as many folks to move to APMs as they are able to do so. We also really want to move away from the siloed reporting structure of the 4 performance categories to ensure that the things that clinicians are asked to do and that they are ultimately assessed and scored on are meaningful and appropriate to their scope of practice. We also anticipate as part of that, we could have a much higher focus on some of our performance categories by trying to link the measures and activities in a little bit more granular detail than the way it works today, while also keeping a focus on reducing administrative reporting burden. And then, of course, really keeping the patient at the center of our work. That's something we always do here at CMS, but as we work to move the quality payment program forward, we feel it's really critical to ensure that the patient is really accounted for as we work to build out our MVPs. So let's move on to the next slide, where there's a diagram of what MVPs could look like. So again, for folks who participated in a QPP session previously, this diagram may look familiar to you. It really hasn't changed from last year. So let me just briefly walk us through it to make sure that folks are tracking to this. So when you look at the left-hand side of this diagram with our 4 separate triangles, that's what we've been hearing from folks on what the current structure of MIPS feels like, where it's really 4 very different and disparate things. The total number of things that we're asking folks to do, when you sum up those numbers, it comes closer to 15 or 20 things that folks may be asked to do. It seems like there's a lot within there. And again, there isn't necessarily always a rhyme or reason to the measures or activities that may be selected from one performance category to another. So then as you look to the middle column of the diagram, that's where we start implementing our MIPS Value Pathways. So again, as Katie mentioned, the MIPS Value Pathways will begin next year in 2021. We do not currently have any MIPS Value Pathways available for reporting. That's a common question we get asked. So again, MVPs are not currently yet available. They will start being available next year in 2021. But as you can see within the diagram, 3 of the performance categories, quality, improvement activities, and cost, we start seeing much closer alignment across those performance categories. And you also can see we have our foundational layer, which consists of the promoting interoperability performance category and our population health metrics. So let me explain that foundational layer in a little bit more detail, because we also get a lot of questions there. So some of the common questions we get are, what is the foundational layer and how does it work for a given MVP? So the way that we view the foundational layer is that it would be MVP agnostic. So regardless of if the MVP is focused on a particular specialist area of focus or a particular condition of care, what consists within the MVP or within the foundational layer would apply regardless of what the MVP's intent is. And so for right now, we have the promoting interoperability performance category, that entire performance category, as part of the foundational layer, as well as what we've called our global and population health metrics, which right now within the program includes our all-cause readmission measure. We anticipate that those categories could function somewhat similarly to how they do today. Then as you look to the most right-hand side of the slide, you see the future state of MIPS, which will continue to evolve over the coming years. But as you can see, we start seeing an even higher focus and linkage of quality, cost, and improvement activities, while still really keeping the patient first and foremost within the MIPS value pathways. We also start seeing a further expansion of the foundational layer to include, again, areas that are really specific to the patient, so patient-reported outcome measures or other patient experience metrics, as well as the ability for us, CMS, to provide additional enhanced performance feedback. Some of the things we've heard from folks that they would like to see is additional patient drill-down information. So we anticipate that that is something that we can continue to expand on over time. So let's move on to the next slide, which has another MVP diagram. This one is specific to a specialty, so for surgeons. And this is an example of what an MVP could look like for general surgeons. Again, it's just an example. This is not a currently available participation option. It's just an example so folks have a sense of what we anticipate the MVP could look like. And I'm just going to focus on the call-out box in the middle of the slide there. So you can see, just looking at the 3 performance categories, quality, improvement activities, and cost, the total number of things that people are asked to do is significantly reduced. So under quality, we just have 3 quality measures selected. For improvement activities, just a couple improvement activities. And then we have 1 of our global cost measures and 2 of our episode measures that we feel could apply to general surgeons. And then on the next slide, we have another example of an MVP. Again, this MVP is focused on the care of patients with diabetes. So again, just focusing on the call-out box again, you can see a smaller set of quality measures, improvement activities, and cost measures. So we anticipate, as the MVPs continue to get built out and developed more along with our stakeholders, the total number of things that clinicians will be asked to do under the MIPS program through the MVP participation option, that again, those total number of things can be significantly reduced, while also at the same time really focusing clinicians' efforts on the areas that are most meaningful to their practice. So those are things that we will continue to do over the coming years. Let's move on to the next slide, where, again, some of the MVPs, what will they do? We anticipate that the MVPs will really reduce reporting burden by being able to, again, refocus a clinician's efforts on a distinct either episode of care, areas that are specific to their specialty, or other high areas of patient care. And then moving on to the next slide, so some of the next steps as we work to continue to move the MVP framework forward. So as folks may recall, we did finalize in last year's rule the MVP framework itself as just a subset of measures and activities. Again, that will begin in 2021. We anticipate with the MVPs that we will want to continue to engage with stakeholders and their specialty societies to really build out the MVPs. We've heard from folks both through the RFI we've had last year as well as through a number of listening sessions that while folks are very much in favor of the new MVP approach, they don't want us to make the transition to MVPs too quickly, that we really need to ensure that we have the time to build out these MVPs where they really can account for the areas that we really want to focus clinicians' efforts on. So as you can see on the slide here, we really are committed to working with all of you as we work to build out the MVP inventory. And then moving on to the next slide. So we are beginning to enter our rulemaking cycle, which for, as many of you know, it's an annual process that we go through here at CMS under the Quality Payment Program. Once we enter our rulemaking cycle, we unfortunately are limited in some of the details of our policymaking thoughts, and that's really just to protect the integrity of the rulemaking process. So we do apologize for that. But we do anticipate that MVPs, there will be numerous opportunities to engage with us as we work to build out the MVPs moving forward. We are just beginning our development efforts of MVPs for the 2021 as well as future years. So to really make sure that you are staying up to date on development opportunities, please make sure that you're signed up to our QPP listserv. So at this point, let me go ahead and turn the presentation back over to Katie to go over some of our resources that we have available. Katie?
Great, thanks, Molly. So a lot of what we've seen today, so our diagrams that Molly walked you through are available on our QPP resource library on qpp.cms.gov. There is also an MVP's video that's available, and then a number of different, our fact sheet about MVPs and all of the diagrams and video that we've walked through today. So we encourage everybody to go there and look at that information. Next slide, please. And this slide just, if you would like to participate in our with one of our QPP research teams, we do really try to make our program as human-centered as focused through human-centered design efforts. So here's just some information on where to reach out to and what information they need if you want to participate in any of our research efforts. And these, I should say, this is not specific research just to MVPs. This is the program in general. They have different topics that they're looking for research on throughout the year. So if you want to participate, this email address at the bottom, qppuserresearch@cms.hhs.gov, is the best way to contact that team. Next slide, please. All right, and then this slide just goes through some other additional resources that are available. So for our small and solo practices, we have our small, underserved, and rural support team is available, and their contact information is right there. So qppserves@impactint.com. And you can also reach them by contacting our service center, so Quality Payment Program Service Center. Their information is on this slide, but it's also on our QPP website at the bottom of I think just about every page to reach out to them with any questions that you have about the program in general. We have some really knowledgeable agents that are available to help walk you through your specific scenario or get you in touch with some technical assistance that might be available. Again, we have our Quality Payment Program website that is a really great tool. There's a lot of tools on there to help you figure out the best way to participate in the program that makes most sense for you, and a lot of other really good resources to help you participate successfully in the program. And then on our APM side, there is the Center for Medicare and Medicaid Innovations. Their learning systems are also have information available on the website. Next slide, please. And one more. So before we get into our Q&A session and we turn it back over to our Ketchum team, we'll just walk through just a couple of kind of just thought-provoking questions that as you think about things that you might want to ask about MVPs. So do you have any questions or concerns about this new framework that we've outlined for you today? What additional information do you think would be helpful for you on this topic specifically? Next slide. We really love to hear any and all feedback. So what have you been hearing from the clinicians that, if you're a clinician yourself or clinicians that you represent about moving to MVPs? How are people, what do they think about it? Do you have any suggestions for improvements where we can just make this participation framework as meaningful as we can to all clinicians? So again here, what would these clinicians like to see happen? And thinking about MVPs and burden reduction, what do you consider a priority that CMS really needs to pay attention to X, Y, or Z for MVP development? I know we've talked about it a lot before, and Molly's talked about it a lot, that we really want to make development of these in partnership with our stakeholders. And with that, I'm going to turn it back over to Ketchum. They're going to walk us through how you can participate in our Q&A session.
Okay, great. Thank you, Katie. All right, so we are now starting the question and answer portion of the webinar. We have now opened the chat line as well as the questions box. So if you'd like to ask a question either way, please do so by either submitting a question via the chat box on your screen and we can read it out loud. And otherwise, if you'd like to raise the green hand icon on your screen, if you click that, it'll come up with a hand icon next to your name. And we can go ahead and unmute your line, and we will always say your name before unmuting your line. So just to get started, we have a few questions on how MVPs and MIPS will work in future years. So first question is, are we understanding correctly that MVPs will eventually become the only way to complete MIPS reporting?
Sure, this is Molly. So it's a great question. I can't give you guys a firm answer because that is something that we will address through upcoming rulemaking. I can share a little bit more of our current thinking regarding MVPs, though, and the MIPS program. So we do see a lot of potential benefit with the new MVP framework. We do, however, want to make sure that we can implement the MVPs in a manner that works for all participants. And so because of that, we do agree with the feedback we've been hearing from folks that we want to move to the MVP framework in a really thoughtful manner. We don't necessarily want to have, MVPs that come out that are poorly crafted, where we could just recreate a lot of the same problems that currently exist within the MIPS program. So, I think we want to see how the MVP program or the new participation option continues to evolve, and then we'll address what the timeline would look like of potentially ending the current MIPS participation option. Overall, until, if and when Congress actually, or up until they change the law, the MIPS program, as well as the APM program, so the overall quality payment program, those will still continue. It's just the methods of how people could participate. Those are some of the things that could change through upcoming rulemaking. Thank you.
Okay, great. Thank you for that. All right. Another question that we're seeing a lot on are you planning, or how will you plan to address MVPs for groups that have multiple specialties?
Sure. So this is another question that we get asked a lot. So one of the benefits that we really see of MVPs is that it can, again, address a number of the issues that have inadvertently been created within the MIPS program. And one of those is we've seen a really large uptake of participation of clinicians as part of a group, which that is not a problem. We think that's a great thing. We're really happy to see that clinicians are participating in the program really through whatever means they've chosen to do so, which makes sense for them. But what we are seeing is that the majority of clinicians who are participating as part of a group, they're typically reporting and then being scored and assessed on a set of primary care or preventative healthcare metrics. And when you think about multi-specialty practices, a number of different clinicians can participate to overall preventative healthcare, but we also recognize that just focusing on those types of metrics, it excludes a number of specialties. So one of the additional benefits that we see of MVPs is the ability for clinicians to be able to report and be scored on measures that could be more meaningful and more appropriate to their specialty and or their scope of practice. We have solicited comments on different approaches on how we can have a fuller comprehensiveness of the group, really for the past few years under the MIPS program. We've sought comment on approaches of either sub-TIN or sub-group reporting and or other approaches. So those are things that we're continuing to think a lot about as we work to move the MVP framework forward. We do recognize that different approaches could have different impacts on the overall burden of clinicians collecting and reporting information in. So those are things that we're very much keeping in mind while also ensuring that we can really ensure that the program isn't, a check the box program, but one that does have value. And as part of that, we do see a benefit of really being able to assess and score clinicians on measures that are meaningful and appropriate to them. But so another long way of saying this is another item that we'll be addressing through our upcoming rulemaking cycles. But I hope that shares a little bit more of our thinking related to that issue.
Great, thank you for that. All right, next we will go to the phone line. We do have a question from Trudy Piercy. So Trudy, we've unmuted your line and you can go ahead and ask your question.
Mine are suggestions or comments. I have two major ones. When you're going about the final rule or guidance for this MVP framework, please keep in mind universities that are teaching hospitals, because we cover the primary care, we cover lots and lots of specialties, and that reporting burden is going to increase dramatically as these MVPs are rolled out. That's number one. Number two, when you're rolling these MVP frameworks out, keep in mind that when you go to standardize some measure specifications for those MVPs, that you continue to use three terms that CMS set out in final rule, and those are collection type, submitter type, and submission type. Those three terms were fairly straightforward in final rule of 2019. I think they could be clearer, but I think an example of the confusion still remaining around those is the CQM specifications still has a paragraph for measure submission type that doesn't follow the same rule language as was in final rules. So when you go to do this for the MVPs, words matter, consistency of words matter, and consistency of terminology matters. So please stay true to the collection type, submitter type, and submission type, and maybe even get more precise in those three terms when you do the final rule. Those are my suggestions.
Thank you for that feedback. That's really helpful, and thank you for flagging the inconsistency within our specifications. We'll definitely work to clean that up. Thank you.
Okay, great. We do have a few more people on the phone line either wishing to ask a question or to provide feedback. So Keenan Bora, we're unmuting your line. And Keenan Bora, you may go ahead.
Hi there. I'm a practicing emergency medicine physician, and there are a couple of questions that I had with respect to these. One would be the issue of data collection, and specifically, a lot of these programs require groups to get information from the hospital, and I'm wondering what CMS is doing to encourage hospital systems to give their provider groups accurate and meaningful data. And then two, with respect to cost attribution, how do you anticipate attribution of cost to a specialty like emergency medicine, where, if I understand a lot of these MIPS value pathways, we have overlap with a lot of them, but we really don't have a significant contribution to the overall cost of care for an episode? That's it.
Yeah, thank you for those clarifying questions. This is Molly from the CMS team. Do we have the appropriate SMEs on to answer those questions?
Oh, sorry. Can you please repeat the question? Sorry about that.
Sure. I have two specific questions. One is, I'm practicing emergency medicine physician in a large multi-specialty group covering about 650 emergency departments. And so we have to work with a variety of different healthcare systems. And I'm wondering what CMS is doing as far as encouraging the hospitals to provide provider groups with accurate and clear data with respect to this. Question number two is with respect to cost attribution for emergency medicine. It's challenging to come up with a MIPS value pathway that doesn't in some way involve a certain aspect of emergency medicine, but I'm hesitant to encourage emergency medicine to take on the overall cost of care for a group or an episode or a particular topic that we have very little control over overall. And I'm wondering how we deal with the questions of cross-specialty cost attribution.
Thank you for repeating that. So in terms of the first question, I think what you're getting at is the question of how we're reporting to multiple specialties within a given group, in a given group, and I think that's not specific just to even to a hospital or a large system, but in any group where you have multiple specialties represented, there's a question of what kind of reporting is going to be involved. I think the answer to that is that we don't really have an answer yet as to how we're going to approach this. We're interested in taking in feedback from you about it. The fundamental tension that we face is that, yes, we want to be able to get data that drives at all of the specialties that are represented in a given group. And we think that that's an important aspect of ensuring that the program incentivizes quality improvement overall. The trade-off to a lot of the options for doing this is that it requires greater reporting burden on the groups that are implicated in that scenario. And I think what we're trying to figure out is how to find a way to get that information available not only within the program but also in the performance feedback without overloading provider groups with reporting requirements. We've talked a little bit about how we may see this being done with EHRs as API technologies evolve, but in terms of how we can go about doing it right now, I think that's something we don't have an answer for yet. I'm sorry I don't have a more definitive response to give you at this point. I think the second piece to it is more a question of how to get a cost measure that is applicable to a given specialty. And this is an issue that's come up in our recent discussions around the sepsis measure, because the sepsis measure, while sepsis is an issue that is frequently seen within the emergency department, as you're certainly aware, the attribution of the measure is not necessarily to the emergency department physicians. And so one of the things that we've been talking about within the work group, the subject matter expert work group about this, is how we might try to address an issue like sepsis that is relevant to the emergency department without then applying to them service assignments that are entirely outside of their control. For instance, in terms of what would happen following in a subsequent hospital admission for a patient who came in who was septic, and so I think the ideas that have been discussed have included building measures that are specifically targeted to the emergency department, but with a limited set of assignments, or alternatively, incorporating emergency department attributions for a set of assignments within existing cost measures. Again, we don't have a definitive answer for what that's going to look like, but this is an issue that we're discussing, and we'd certainly be interested in hearing your feedback about which of those options seems like it would make the most sense from your perspective. So I hope that's helpful. But if you want to discuss it more, we have a help desk ticket or a help desk, and we'd certainly encourage you to submit your thoughts or questions to us so we can take a look and respond.
Okay, great. Thank you so much for that. All right, so going back to the questions box, another question is asking, will MVP measures be finalized in time for IT systems to configure their systems for new measures and new ways of reporting, as more time is always needed to make systems work for clinicians?
Sure. So this is Molly. So I think the question is, what is the timeline related to when measures and activities would be finalized, and will we account for any time needed for updates to EHR systems? So to address that, so as I've mentioned a couple times here today, we do anticipate that the MVPs themselves, so the specific selection of measures and activities that would fall into any given MVP, that would be addressed through our annual rulemaking process. So folks definitely can and should stay tuned to our rulemaking processes this year, so they can see what the MVPs are shaping up to look like. For the concern regarding, ensuring there's an appropriate amount of implementation time to update systems and processes, we definitely understand and appreciate that. We're taking a close look at all of our existing timelines of getting measures and activities into the program and all of our processes to ensure that systems can be updated to account for these items. So that those are also items that will be addressed through this upcoming year's rulemaking process. I hope that helps. Thank you.
Okay, great. Thank you for that. All right, another question is on the population health measures, asking for clarification. So could you please clarify the population health measures, and if possible, can you please provide an example of population health metrics that are part of the foundational layer of MVPs?
Yeah, sure. This is Molly again. I'll start, but if other folks from the CMS team want to jump in, please feel free. So as I mentioned earlier on, for the role of the population health metrics that could fall within the foundational layer. So what we mentioned within last year's RFI is the potential inclusion of our one existing global and population health measure that we currently have within the MIPS program, which is our all-cause readmission measure. This is a measure that we, CMS, calculate on behalf of clinicians that aren't considered to be part of a small practice, so anyone that's part of a organization with 16 or greater clinicians. We go ahead and attempt to calculate that for your group, And if we are able to do so that meets our reliability thresholds, we go ahead and add that measure to your overall quality performance category score. We do see a benefit of increasing the population health metrics, or really any of these global administrative claims types metrics, for a couple of reasons. And let me also clarify, when we refer to population health metrics under MVPs, we don't really, I will say that we are working on a more refined term for these measures here. We do see the value in population health metrics that really can be measured at the population level. However, what we're really looking to do under the MIPS program is really measure, or to have some of these measures assessed more at the community or group level. And again, that's just to maintain a lot of our statutory requirements. But as we think about the quality payment program landscape, and as we think about APMs, they oftentimes have many more population health metrics, because when you think about the APMs, they're really trying to improve the overall health and care of the patient population that they serve overall. So we do see a significant benefit for these types of metrics within the program, and that is an area that we are looking to expand upon in the future. Another reason why we also like these types of measures is they're typically drawn from data that comes from what we call administrative claims, and that's data that we CMS have available in-house, which requires no separate collection or reporting burden. So we simply can calculate the measures based off of the available Part A and Part B data that we have available within the program. I hope that helps clarify where our intention there, but let me pause to see if any other folks from CMS want to add in anything else.
Okay, thank you. All right, we'll take a few more questions from the phone line. Your next question is from Marvin Gallo. So Marvin, we're unmuting your line. All right, Marvin, you may go ahead and ask your question.
Hi, yes, my question is actually related to the cost measures. I was wondering, in the past, practices who had access to the QR/UR reports were able to utilize that data to analyze the provider performance under certain cost measures. But it looks like that data is no longer available, and I'm wondering if CMS is going to make something of the like available in the future for practices to be able to address cost performance in a timely manner during the performance year, as opposed to later in later years after the performance year has already been addressed.
Hello, this is Joel. So I think, how do I put this? So we've been working on providing additional information on the cost measures. I think the specific response probably depends on exactly what from the QR/URs you are wanting to see replicated. If you can submit a question or submit a message in the help desk that specifies exactly what information you're looking for, then I think it would probably give you a more specific response. But generally speaking, yes, we are interested in looking at what kind of feedback to provide about the cost measures, and we're interested in finding out what information, finding out from you what information would be helpful for you to receive. So if you have specific examples of what you'd like to see on the measures, we'd certainly love to see that, so we could take a look at how that information can be shared.
Wonderful, thank you.
All right, thank you. Next question is from Nirvish Shah. So Nirvish Shah, all right, if you would like to unmute your line, Nirvish, you may go ahead. Okay, perfect. Nirvish Shah, we are unmuting your line, and you may go ahead and ask your question. Nirvish Shah, you may go ahead and ask your question. All right, lovely. We will move on to a question by Alexis Shaner. So Alexis, we've unmuted your line, and you may go ahead.
Hi, thank you for taking my call. The question I have, I think, has been covered multiple times, just related to the multi-specialty groups and the concern about the MVP causing additional administrative burden to organizations that do have multiple specialties in the TIN. One question specifically that I had was related to the benchmarking and how that would work in relation to the specialists. If it looks like we're going to have to either attest or submit based on the provider specialty.
Sure. This is Molly. Could you maybe just add a little bit more to your question? I don't know that I'm fully understanding.
Oh, yeah. So I guess basically right now what we're seeing is that we're submitting as a group, and with our specialists, we're able to submit with collective aggregate data. With the benchmarking approach, the fear is that the specialty providers who have particular patients with conditions are going to be benchmarked against other providers who are something like primary care or another specialty where the numbers might be higher. So I'm just curious as to how the weighting of the benchmarking would change with the MVP.
Okay, thank you for clarifying. So unfortunately, that's something that will be addressed through the rulemaking process, so we can't get into those details, but I will say if you have any feedback that you want to share with us on a preferred approach over another, or an approach that you would not like us to see, definitely, receiving that feedback either here today or, as my colleague Jewel has mentioned a couple times, you can share that with us through our help desk, the QPP@cms.gov service center. Having any additional feedback related to that would be really helpful.
Great, thank you.
Okay, great. Thank you for that. All right, next question is a bit of feedback as well. It says, please keep in mind that the promoting interoperability category is waived for hospital-based and non-patient facing groups. Will this continue with the new program?
Sure, this is Molly again. So again, that's a subject for rulemaking, but we do anticipate that the promoting interoperability performance category will function similarly to how it functions today. Thank you.
Great, thank you. All right, and just as a reminder to everybody, in the last 10 minutes, we will provide the feedback questions, present them back on your slides. So if you would like to provide feedback on that, please feel free to raise your hand, and we will unmute your line. All right, your next question is from Deanna Knight. So Deanna Knight, we're unmuting your line, and you may go ahead and ask your question. Deanna Knight, you may go ahead and ask your question. All right, we will move on to a question by Madison Danes. Madison, we are unmuting your line, and you may go ahead and ask your question.
Hi there. I was wondering how MVP will interact with MIPS APM. Would practices still get to do normal MIPS APM if they qualify, or will that be adjusted to upcoming rulemaking?
Yeah, thank you for that question. This is Molly again. That will be a subject for rulemaking. We are taking a close look at, so overall I can say for MVPs, we're really taking a close look at all of our existing policies, regardless of if they're related to eligibility, any of our specific performance category policies, the required number of things that folks have to do, or scoring policy, so how we, benchmark any of the given measures, and or how the overall composition of measures contributes to a performance category or final score. And again, for the question here, the intersection of the MIPS APMs that fall under the scoring standard, how that would work under the new MVP framework. So we are taking a close look at all of that, and we will be addressing any of those changes through upcoming rulemaking. So again, just because I've mentioned it a couple times here today, for folks who want to take a close look at that rule when it comes out. Highly recommend that you sign up for our listserv, which I know we had on a prior slide, and then also our rulemaking that our policies come a part of is the physician fee schedule, which typically is made available to the public around this summertime, around late June, July. So I hope that helps. Thank you.
Okay, great. Thank you for that. All right. Your next question is asking about EHR capabilities. It says, will there be a hardship waiver built into the reporting program or any other kind of flexibility if EHRs cannot meet the needs based on program requirements?
Sure. This is Molly again. Not to sound of a bit of a broken record, but again, that is something we would consider through the rulemaking process. I would ask this commenter questioner though, if they have any additional context that they want to share with us related to circumstances on why they feel that this exemption may be needed and what those could look like. That would be helpful for us to take into consideration as we're thinking about this.
Okay, great. Thank you. All right, we do have a few general questions on MVPs coming in. So first, can you please provide some clarity on whether CMS will decide what MVPs clinicians will need to report on, or whether that will be up to clinicians themselves?
This is Sophia. I think through the 2020 final rule and the RFI that we did on the MVP framework, we've emphasized that we want this to be a collaborative process of us developing these MVPs. We don't want it to be perceived that CMS is developing these MVPs and expecting clinicians to just report on what we have. We anticipate we will continuously have these close stakeholder engagement to come up with MVPs that are meaningful and relevant to the various specialties or subspecialties that are out there and reporting to MIPS. So that is a process we anticipate we will continue to use as we build for 2021 and for future years.
Okay, thank you. All right, we have about 4 minutes left, so we'll try to take as much feedback from the phone as possible. Deanna Knight, we will unmute your line. Deanna Knight, you may go ahead.
My question was already answered. Thank you.
Of course, no worries. All right, we'll go back to another question from Keenan Bora. You may go ahead.
Hi, it's just more of a general comment regarding CMS quality, which is that, we've got a lot of these different groups that are sort of trying to figure out and validate quality data and how do you get them and how do you submit it. And it's just a thing to take to the powers that be at CMS to consider maybe having an interface where the hospitals and the EMRs give all of the data directly to CMS. CMS creates a general access web page that provider groups could come into and then submit the quality measures that they feel are most representative or paint them in the best light, and that they feel like are accurate reflections of the data. This might, if you're talking about reducing the administrative burden overall, having a central place where all of that stuff is already done and we can just call in and log in and say, yes, I agree to that, that would get you, if not accurate data, at least consistent data.
This is Molly. Thank you for that feedback. We're definitely continuing to look at evolving data standards to leverage those as much as we can as we work to continue to move the program forward. So thank you for that feedback. We really appreciate it.
Okay, great. Thank you for that. All right, and as we're nearly out of time, Molly and Katie, we will pass it back to you to just close out and go over any last-minute MVP resources you can.
Great. Thanks, Lauren, and thanks everybody for your participation today. We really appreciate the discussion and look forward to talking with you all soon. Again, I'll just plug the QPP listserv on qpp.cms.gov. It's the best way to stay in touch with us and be notified as soon as any additional MVP information is available. Thanks. Have a good day.